All right. Hello, everyone. Welcome to the Buprenorphine 101 webinar on demystifying medication-assisted treatment in Wisconsin. My name is Shruti Murali. I am an improvement advisor at the Wisconsin Hospital Association, and I'll be coordinating today's event. We have three primary objectives for today. Number one is to understand the DSMV definition of substance abuse disorder and apply it to your patient population. Number two, understand when an X-waiver is required to prescribe buprenorphine and what is covered by the 8-hour X-waiver training. And number three, understand the most common way that buprenorphine is prescribed in both emergency departments and primary care offices. Those participating in the live session have the ability to earn a continuing education credit. This webinar is approved for 1 continuing education credit for physicians and nurses. After the event, I will send you all a document containing instructions to claim your credit. For those of you not familiar with this technology, we are using a web-based video conferencing platform called Zoom. As of now, all of your mics are muted. If you have any questions or comments, please put them in the chat and we will respond to them as we get to them. This event is being recorded and a link will be made available to you soon. If you have any questions, let us know. Otherwise, let me go ahead and introduce you to your facilitator for today, Dr. Bobby Redwood. Dr. Bobby Redwood is a graduate of the Rush University School of Medicine in Chicago and the University of Wisconsin Emergency Medicine and Preventative Residencies. He works full-time as an emergency and preventative medicine physician at Divine Savior Hospital in Portage, Wisconsin, and is chair of the hospital's Antimicrobial Stewardship Committee. Dr. Redwood also teaches resident physicians and publishes research as a clinical adjunct professor for the UW Department of Family Medicine. Recent publications include severe sepsis care in the emergency department and antimicrobial stewardship in the emergency department. Outside of work, he serves as a national counselor and past president of the Wisconsin chapter of the American College of Emergency Physicians. So now I'm going to hand it over to Dr. Redwood.
Thank you, Shruti. So welcome everyone to our afternoon webinar today. I'm really excited that WHA is moving into the space of working to curb the opioid epidemic. And really one of the greatest needs in Wisconsin right now are X-waivered providers to provide medication-assisted treatment, specifically buprenorphine and combination medications. And if you thought today was an X-waiver training, it's not. Stay with us. That's an 8-hour commitment. But I think that you'll find this is really useful because what we're going to do is just break it down to the core components of how this really works, how you operationalize medication-assisted treatment, both in the emergency department and in the primary care clinic. So I have no disclosures, and we're going to dive right in. The goals of the presentation today, we want to explain the mechanism of action and the evidence behind MAT, make sure everyone's on the same page in terms of what you're prescribing and how it works. We'll explain the role of the emergency and primary care provider, and then really get into the X-waiver training process and just sort of lay it out to you what we do in the trainings, which trainings are being offered in Wisconsin this year, how you can get yourself X-waivered. What we will not be doing today, this is not a substitute for a DEA-approved X-waiver course. So that's a special addendum to your DEA, and it does require the training. And we really are focusing today on buprenorphine because that's the most friendly medication-assisted treatment for the ED realm. But we don't want to discount the role and the importance of methadone or extended-release naltrexone. Those are both absolutely fabulous therapies. Those are evidence-based and useful, but they're outside the scope of the webinar today. And then the framework that we're using today is called the Yale protocol. It is the most evidence-based and most tested protocol for buprenorphine starting in the ED, but there are various other protocols out there. Specifically for office-based outpatient treatment in the clinic, you may be using a different protocol. That's perfectly okay. In my experience, they're all quite similar actually, and so you will find useful information in the Yale protocol even if your health system uses something slightly different. And then really an additional goal of this presentation is to encourage both emergency physicians and family practice physicians to start talking about MAT. It's possible to prescribe MAT in a vacuum, but it's much more provider-friendly, patient-friendly, and really just sustainable to have a system in place where the entire ED and family practice group have a coordinated care pathway in place to meet these patients where they are, get them the help they need. My hope is that at the end of this webinar, some or all of you are motivated to ask yourselves whether your care environment has an MAT care pathway in place, and if not, what the next steps are in terms of getting that care pathway set up. clicker issue. Now I'm not gonna belabor the fact that we have an epidemic going on in Wisconsin too much. I think you've all seen the curve. So it is an exponential curve at this point, and we are not seeing that arc where the bell curve, where the exponential curve becomes a bell curve. So in 2018, nationwide, we had 72,000 opioid deaths. It is a record. It is the deadliest drug epidemic in our nation's history, and it is now killing more young people than all other diseases, including car accidents. So if you are ages 18 to 44 in the U.S. right now, your most likely cause of death is an opioid or drug overdose. In 2017, Wisconsin had the ominous honor of having the greatest increase in ED overdoses in the nation, and so we had a 109 increase in ED overdoses in that year. Basically doubled our ED overdoses. And that's a big part of the reason I really want emergency physicians and PCPs to start talking, is because the ED is uniquely positioned to intervene in this epidemic, but it has to be a partnership. We need to have the place to refer patients to. We need to have care processes in place to make this actually work. Now, what the graphic here depicts is that emergency physicians can actually look at patients' ED use patterns and risk stratify the risk of dying from opiate use disorder. So if you see a patient who's had 4 ED visits in the last year for opiate use related issues, they are at very high risk for death. That's a patient where you would want to see if it's the right time to start having this conversation about medication-assisted treatment. It really sets us up for a potentially powerful conversation about the course that the patient's disease is taking, and if that patient is willing, opens up an opportunity for us to discuss medication-assisted treatment and hopefully get them into a care pathway to get them the medication that they need. Patients with opiate use disorder end up in the ED. They just do. Suffering from side effects of abuse like skin infections or endocarditis. We see them suffering from effects of opioid-seeking behavior, if they're an unrevealed addict, or behavioral health emergencies, even in police custody. And then, of course, suffering from things like overdose or respiratory arrest. That's really the salient point here, is that emergency physicians are particularly motivated to combat this crisis because we see opioid use disorder population at their most vulnerable moments. Now, I do just want to take a moment here to do a little myth busting and emphasize that emergency physicians are actually very low-risk providers of opioids. There was this flurry of misguided public policy work a few years ago that focused on the emergency department's role as a pipeline for opioid prescriptions, despite very good data showing that EDs are responsible for only 5% of opioid pain relievers in most communities. So EDs may account for 5% of total opioid prescriptions, but we tend to prescribe very small pill counts of low-strength, immediate-release opioids. So the actual contribution of opioid morphine equivalent into a community is very low. There was a study of patients who died of prescription drug abuse, and it was found that ED prescribers accounted for only 1.5% of pills prescribed to patients in the 12 months before their deaths. And the authors concluded that although patients who subsequently die from substance abuse frequently end up in the ED, they are actually receiving most of their pills elsewhere. I think that's important to mention just because emergency providers are sometimes reticent to enter this space. They say, you know, I don't know if I want to be associated with this opioid epidemic. I don't want to be seen as contributing to this. There's some fear that we're actually switching one addiction for another with buprenorphine, which we will thoroughly debunk that myth today. And so I just want to kind of throw that out there, that this is really a good faith effort from emergency physicians and, of course, family physicians as well, to just reach out to this vulnerable population wherever they are at. Now, this slide lays out the FDA-approved forms of MAT. That's medication-assisted treatment, including their cost and abuse potential. So each of these medications may be the most useful choice depending on your patient's individual circumstances. That being said, methadone's not really an option in the ED because it has to be dispensed in highly regulated clinics, and it does have a high potential for abuse or overdose. So it's usually an observed administration. Similarly, extended-release naltrexone is not really applicable in the ED because it can precipitate severe withdrawal, and that's the exact side effect that active opioid users fear the most. So that really leaves us with buprenorphine and then combination buprenorphine products like buprenorphine naloxone. And I'll just note that naloxone on its own is used as an antidote for overdose, and so that's not as much medication-assisted treatment for getting patients off of opioids, but to rescue them when they have respiratory depression or overdose. So the most elegant combination here, or the most elegant choice, is buprenorphine and naloxone, and there is a common trade name for that, which I think most of us know. We're not allowed to use trade names in this webinar. But it achieves a similar effect as buprenorphine alone with very little potential for abuse. And just to clarify this point further, the naloxone in this combination product has no effect if the pill is taken orally or sublingually. Basically, if the drug is crushed, dissolved, or injected, as a drug of abuse. So if someone gets buprenorphine naloxone combination and it tries to abuse it and inject it, the naloxone then becomes active and prevents any euphoria from the partial mu agonist buprenorphine. And that's why it's such a useful drug in combating this opioid epidemic. That's probably a good segue into the pharmacology of these medications. I want to keep things really simple here. And I think this cartoon actually does an effective job of that. Here's how I think of it. The portion of the blue hexagon that lies above the dark blue line there is the amount of high that the patient is going to get from this medication, the amount of euphoria. So full agonists like heroin, oxycodone, fentanyl, etc., those give patients a very large euphoric effect. And then a partial agonist like buprenorphine might give an opioid-naive patient some appreciable high, but it's unlikely to give any sort of euphoric effect to a patient who's already suffering from opioid use disorder. More importantly, buprenorphine and also naloxone bind to the mu receptor with a much greater affinity than the drugs of abuse. And so they're basically treating the cravings of addiction without throwing the patient into withdrawal. And that's really the key about all of this. A common critique, as we mentioned before, is this fear that we're going to be substituting one addiction for another. And this point comes up again and again in this presentation. What we are substituting addiction for dependence. So the buprenorphine patient will absolutely still be dependent on this drug. There's no doubt about it. But they will not have the same cravings of addiction that they had with heroin or prescription opioids. And it's the cravings that drive patients to miss work, neglect their families, lie to providers, break the law, do anything they can to get opioids. It's the cravings that ruin patients' lives and perpetuate the downward spiral of escalating of tolerance and abuse. So the goal of MAT is to substitute addiction for dependence and liberate patients from their cravings so they can start building the foundation of a healthy and productive life. That being said, they may be on buprenorphine therapy for years. They might be on buprenorphine therapy forever. Some patients are able to taper their dose down after years, but some patients live in a perpetual state of dependence, and it becomes a chronic medication just like a hypertension pill or a diabetes pill. So it begs the question, right? Does MAT work? Is this ready for prime time? MAT works, period. If you want to know more, there's a Cochrane review on the buprenorphine specifically. It includes 27 randomized controlled trials and over 3,000 patients. Patients on buprenorphine stay in counseling longer, they complete counseling or treatment programs more frequently, and most importantly, they suffer from fewer overdoses and they just live longer. Probably even more impressive than these results is that these results have been reproduced on a large scale through buprenorphine-focused public health initiatives. The most notable example is the country of France, the entire nation. They had this massive heroin epidemic in the 1990s that essentially reduced the prevalence of opiate use disorder by 80% in just 5 years. What they did was they empowered all general providers to prescribe buprenorphine, and then they made the drug available in retail pharmacies. Consequently, they also saw dramatic drops in drug-related comorbidities, including a drop in HIV rates from 25% to 6% among IV drug users. Again, MAT works. Moving on to our next graph. This basically shows that patients are much less likely to die the longer they remain on medication-assisted treatment. In this graph, they call it opioid substitution treatment. MAT with buprenorphine has a powerful effect on reducing long-term mortality, and the effect is not dependent on cessation of illicit opioid use or drug addiction. So you can actually keep using buprenorphine and you still have a mortality benefit. The key intervention is initiating and sustaining MAT with buprenorphine or methadone. The longer people stay in treatment, and this assumes alternating episodes of relapse and return to treatment. This assumes that you're going to have periods where you relapse and use again. You still have a greater survival benefit. Basically, the longer you use MAT, the longer you survive. Now, as with any medication, it's important to know the safety profile of buprenorphine before prescribing it. And what you'll find is that most patients will tolerate buprenorphine very well. And when you do encounter side effects, they'll be similar to those of opioids in general, or conversely of opioid withdrawal. So common side effects are going to include nausea, vomiting, and constipation. And then less commonly, you'll see unpleasant side effects like headache, insomnia, leg edema, and itching. We're actually seeing those much less frequently than just the typical nausea, vomiting, and constipation. The high affinity, low intrinsic mu agonism can result in precipitated withdrawal if the patients are opioid tolerant and they've not waited sufficiently long to actually go into withdrawal. And so that's probably the main thing is if you kind of overdo it with buprenorphine therapy, you can throw a patient into withdrawal. I think this is just a consequence of prescribing MAT. You will have a small subset of patients where you believe that they are in withdrawal, where you've appropriately gauged whether they're in withdrawal, and even with your best intentions, they still go into withdrawal. Luckily, there's a good way to prevent this and a good way to treat it. So to avoid precipitated withdrawal in patients with long-acting opioids on board, such as OxyContin, MS-Contin, or methadone, just wait for the development of withdrawal symptoms as characterized by a COWS score or a SOWS score. And we're going to get deeper into that. But basically, you want a COWS score of greater than 10 before the first dose of buprenorphine is administered. Typically, that's about 36 hours, but we have a more in-depth slide on that. That's sort of a cartoon graphic on how to wait that out. If a patient does go into withdrawal, you should see that side effect within an hour of giving buprenorphine. So whether you're in clinic or the ED, you'll see these side effects kick in. And the management's actually pretty logical. You will increase the dose of buprenorphine and titrate until the withdrawal symptoms subside. So the Yale protocol is recommending 2 to 4 milligrams oral buprenorphine every hour until withdrawal symptoms have improved. Or if you're using IV or IM formulations, it's a 0.3 milligram IV or IM every 30 minutes until symptoms have improved. And we'll get to more of that later as well. Of note, there are some nuanced considerations in terms of special populations. So for example, HIV patients on triple therapy, liver failure patients, they are not candidates for buprenorphine. We're not going to go deep into special populations on this webinar just because of time constraints. I will mention, however, that in pregnancy, you have to use buprenorphine only. So you can use buprenorphine in pregnancy, but not the combination product with naloxone, as that product can send the fetus into opioid withdrawal, which can actually precipitate preterm labor or withdrawal. So that's one special population. If you have a pregnant population, absolutely check the guidelines on that and make sure you're not using the combination product. So, of course, this is DEA territory. There are laws, there are rules here. We have to follow the law. And that is probably one of the biggest benefits of the X-waiver is really going in depth on all the nuances of the DEA law here regarding the S-waiver. That being said, are you ready to have your minds blown? Any provider with a DEA number can prescribe OxyContin, oxycodone, hydrocodone, the dangerous synthetic opioids that put patients at risk for opioid use disorder. However, only a small minority of physicians and APPs have the DEA X-waiver addendum needed to prescribe the much safer treatment for opioid use disorder, which is buprenorphine. Now, there are some nuances, of course. Buprenorphine is a Schedule III narcotic, as it should be. And the FDA-approved formulations for the DEA X-waiver are actually pretty limited. So if you are a pain specialist, you have a lot more options than if you have the X-waiver. But there's plenty of options with the X-waiver. So they are oral buprenorphine plus naloxone, sublingual buprenorphine. There's actually a buprenorphine implant, and then extended release buprenorphine. And so if you have the X-waiver, you can prescribe any of these. The X-waiver is really about prescribing. It's about giving a patient a prescription so they can go to a pharmacy and have take-home medication. Even if you are not X-waivered, there's what's called the 3-day rule, where any opioid, including buprenorphine, can be administered in the ED, or in clinic for that matter, to treat acute withdrawal without a DEA X-waiver. The kick is you can only give it in the ED, so it has to be observed therapy in the ED, and you can only do it 3 days in a row. So you couldn't turn your emergency department into a buprenorphine clinic where a patient comes in every day of the month. And you couldn't give the patient, without a DEA X-waiver, you couldn't give the patient one in the clinic and then some to take home to get them through their PCP visit. So if you're not X-waivered right now, and a patient comes in on a Sunday, and you're pretty certain in your healthcare system you can get them in on a Monday for a follow-up care, you could prescribe buprenorphine on that Sunday and get them follow-up care to initiate induction treatment the next day in clinic. But again, you really have to have a system in place. And it's not going to work that well on a Friday unless your whole group is on board with this care plan, or unless you're working subsequent days, Friday, Saturday, Sunday. And so it really behooves us to get the X-waiver here. This is the issue. And this is really the reason we put this webinar together, is Wisconsin has a drastic shortage of X-waiver providers and a corresponding drastic increase in opioid overdoses. It is a dangerous combination. We have more people overdosing and drastically less providers in other areas in the country. We basically need you. We need your colleagues. We need your affiliated providers in your community, but most importantly, you listening to this webinar to get your X-waiver. The first map here shows just how much of our state is covered. Answer, very little and only in populated areas. If you look specifically, the north, central, and northwest regions of the state are probably our biggest need areas right here. This second map shows our ratio of X-waivered providers compared to opioid overdoses as compared to other states. So the darkest blue regions here represent the greatest shortage of X-waivered providers. And Wisconsin, unfortunately, remains one of the 11 deep, dark blue states, suffering from a critical buprenorphine provider shortage. Deaths due to opioid addiction are continuing to rise, and despite multiple policy interventions at the federal, state, and local levels, we're just not filling the gap. Many of these policy efforts are focused on prevention, and prevention is of course essential. So we actually have an alternative to opioids project here at the Hospital Association to prevent addiction. But this won't help the thousands of Wisconsinites who are already addicted to opioids. The death rate for young Wisconsinites is driven at this point by opioid-related deaths, and it's risen to alarming levels not seen since the height of the AIDS epidemic. And in a tragic reversal on decades of improvement, the impact of preventable mortality from opioid and substance abuse is of the magnitude that we're now seeing a decrease in overall life expectancy for certain demographic groups in our state. So we are actually seeing life expectancy go down because the people who are already addicted are not getting the treatment they need. Now, despite the magnitude of the excess deaths from untreated opioid addiction, access is very limited. Only 24% of patients with opioid use disorder receive medication-assisted treatment. So less than 1 in 4 patients are getting the standard of care for opioid use disorder. And eliminating the disparity here is really our goal. So it starts with us. And if nothing else, if you take nothing else home from this webinar, I ask you to get your X-waiver and ask a friend to get theirs as well. Once you start administering buprenorphine, or you obtain your X-waiver and start prescribing it, there's a very good chance that you'll be functioning either in an acute unscheduled care environment, like an ED or an urgent care, or you're going to be in clinic. And so this slide here really just lays out the emergency provider role and the primary care physician role. The way I have it laid out here is assuming that the patient starts in the ED and translates into clinic. Obviously, if your patient starts in clinic, you would be doing all of this in the clinic setting. And we'll be doing a deep dive on how to operationalize each of these steps. I just wanted to provide this overview slide so that we're all on the same page in terms of how the Yale protocol is laid out and how the buprenorphine prescribing is supposed to flow. So if you look at the left-hand column here, you're going to want to confirm a diagnosis of substance abuse disorder. And there's a standard way to do that and a checklist on how to do that. You are going to want to send screening labs. We'll tell you which labs to send, but basically make sure your patient doesn't have liver failure, HIV, one of these comorbidities, test for pregnancy. You're going to want to treat acute withdrawal symptoms and then coordinate care with a PCP so that you have bridge therapy available until they get to that PCP induction visit. And then once you're in the clinic, that's probably the more nuanced role of actually titrating the appropriate dose, and that is very patient dependent. And then for ongoing therapy, you're going to monitor for misuse and diversion. You want to make sure that this medication is actually getting to your patient and not getting out into the community. You're going to want to check in regularly to see if you can taper the dose down, or at least make sure that the dose is adequate. And then ensure care coordination for therapy and behavioral health interventions. So MAT is one thing, but it works much better if the patient's in treatment or has ongoing counseling. And then plan for relapse. We are in the era where relapse is expected, unfortunately, but that's the nature of this disease. we have fully moved it into the medical arena, and we want to make sure that our patients understand that if they relapse, we're not going to turn our backs on them. We're still going to be there for them, and they can still continue to get medication-assisted treatment even if they relapse. So if you're a visual learner, the Wisconsin chapter of the American College of Emergency Physicians included this graphic in their workforce survey in terms of whether emergency physicians have a positive or negative attitude towards MAT and buprenorphine. And it was very uplifting to find that Wisconsin emergency physicians are ready to treat this epidemic, and they're actually developing their own care coordination pathways in EDs around the state. And I think if any of you out there have a good pathway in place, please share it with the Hospital Association. We're going to be compiling best practices and getting those resources available for other hospitals that are setting things up. So we're very excited to hear who's doing what out there. This graphic basically depicts a comprehensive community model where physicians, nurses, pharmacists, and care coordinators, in conjunction with public health professionals and behavioral health specialists, all team up to treat opiate use disorder and give the patient guidance all the way from acute use to withdrawal to recovery. If you look at this blue box here, this is kind of the space that we're playing with in our webinar today, basically aiming to create a pipeline of X-waivered physician champions and help motivate and inform our community partners to get this coordinated care systems up and running. All right, are you guys ready to dive into our main two topics here? It's time for buprenorphine in the ED and then buprenorphine in clinic. This is how to actually use buprenorphine in the ED, how to use it in clinic according to the Yale protocol. And we'll start right now in the ED. A little bit of history here. Emergency physician Gail D'Onofrio and her staff at the Yale New Haven Hospital recognized early on that the ED has the potential to be a critical point of access for patients suffering from opioid use disorders. So in 2009, she began this groundbreaking program that actually screened patients for opioid use disorder, gave a brief intervention in the ED, and then started the patients on medication-assisted treatment. So the shorthand for this you've probably heard of is SBIRT, screening, brief intervention, and treatment. This is SBIRT plus MAT started in the emergency department. 6 years later, after piloting the program, they published their results in JAMA. So it was 329 opioid-dependent patients, and the results were really impressive. Basically, the buprenorphine arm of the study showed that more than double of the patients that received screening, it showed that the patients who received SBIRT plus MAT were more than twice as likely to still be in treatment 1 year from then. Furthermore, the ED was not overwhelmed with malingering patients. That's a common fear, is that patients are going to kind of seek out your ED to abuse buprenorphine. They did not see that population coming to the ED to abuse the drug, nor was there a significant increase in buprenorphine-related complications, like precipitated withdrawal or overdose. So we already discussed, there's a Cochrane review out there that tells us that MAT works, and now we have an ED-specific study from the Yale group suggesting that ED-initiated MAT with buprenorphine is both feasible and effective. So how do we operationalize it? On the left here, you see the checklist of ED duties when opioid use disorder patients present to the ED. And so again, the cohort that we're trying to capture here are the patients with true opioid use disorder who are already withdrawing and motivated to transition from addiction to dependence. Now, the cartoon on the right here is admittedly pretty gross, but I kind of appreciate the brutal honesty in terms of depicting the suffering that this patient population is experiencing. This is really my average ED patient who's coming in withdrawal. They're ill, they're hopeless, they're in desperate need of compassionate care. And the next few slides are just going to go through 1 through 7. So if you have any questions here, we're going to do a deep dive on each of these bullet points, exactly how to do it according to the Yale protocol. So first is patient identification. Any of the following can be used to clinically identify a patient who should be evaluated for the presence of an opioid use disorder and eligibility for ED initiation of buprenorphine therapy. Again, this step is just about identifying this high-risk cohort for opioid use disorder. An overdose patient is not going to be started on buprenorphine in your ED, but your identification that this patient is high risk may result in an MAT care plan being established as an inpatient, or if they are being discharged, possibly a warm handoff to a behavioral health specialist, even a subsequent PCP MAT referral at discharge. So you're basically going to be trying to find the patients who might be candidates. if a patient requests help, hey doc, I need help to get clean, that's pretty obvious. Or if you hear sort of a passive statement of intent to quit, I'm never using again after this. This might be the powerful moment where you can refer this patient to treatment. A patient who admits to opioid use or has a clinically obvious history of opioid injection use is ripe for intervention. Sometimes when a patient overdoses, we actually bring them back and they are very remorseful and ready to make a change. That's a time when you could consider a warm handoff or a referral. Obviously, you wouldn't start treatment then because they're not withdrawing yet. A patient who's admitted or has obvious use of illicit opioids, so if they have track marks or heroin use, or just if your clinical gut tells you that opioid use disorder might be present. And then it is important to note this last slide, a lot of patients have comorbid substance abuse. So if you're abusing opioids plus alcohol, opioids plus benzodiazepines, these patients are actually not great candidates for buprenorphine therapy as it could throw them into withdrawal from their other substance abuse history. And so it really does kind of have to be that cohort that is explicitly abusing opioids. So that brings us to our next point. You are going to want to have some sort of brief but accurate diagnostic tool that confirms that the patient really does suffer from opioid use disorder. And so this is a great tool. It's a 2-minute rapid opioid dependence screen, the RODS screen. Pictured on the slide here is an example of a RODS form. It was basically adapted directly from the DSM-5 criteria for the diagnosis and has been prospectively validated in multiple trials. So one of your objectives today was to understand the diagnosis of opioid use disorder. It's basically whether the patient scores a score of 3 or greater on the RODS dependence screen. It literally takes 2 minutes or less, and it's basically asking you asking the patient, what drugs have you used, and whether you are experiencing cravings, and whether those cravings are now affecting your behavior and your quality of life. And again, a score of 3 or greater corresponds strongly to a diagnosis of opioid use disorder. And you can easily Google this and get a form that you can adapt for your ED or clinic. Next, the other valuable information that you're going to gather from the RODS score is whether the patient is abusing short-acting opioids or long-acting opioids, or both, which is often the case. Now, it's really fundamental to have a true understanding about this because the timeline of your patient's withdrawal symptoms is intrinsically linked to the half-life of the opioids they're abusing. So if you look at this graphic here, it's basically summarizing the most common time frames for withdrawal. Here in Wisconsin, the majority of our opioid use disorder patients are taking long-acting oral opioids. So that 30-hour window is really important to note. That's going to be the majority of Wisconsin patients based on the demographics. That being said, heroin and fentanyl use are on the rise. Heroin and fentanyl are both very short-acting. And so you have to look for track marks. You have to ask about snorting. If they are using these short-acting opioids, these illicit opioids, your withdrawal may be setting in only 6 to 12 hours. And so that patient may have used at noon, come into your ED at 6. They may already be a candidate for medication-associated treatment or assisted treatment. Now, this is a scoring system to evaluate if the patient is in opioid withdrawal. Most of you are probably familiar with it. It's called the Clinical Opioid Withdrawal Scoring System, or the COWS score. And it grades the degree of withdrawal. It's been around since 2003. It's very well validated, and it is essentially the standard of care for scoring withdrawal. In the Yale protocol, we're recommending just a slight tweak on this for emergency providers. It's called the SOWS score, and it's a slightly modified COWS that saves your triage nurse a few minutes. And so what we're showing here is actually the SOWS score. You can review the questions here. Your role as a provider is to interpret the score, interpret the results. So specifically, a score of less than 12 is mild withdrawal. If you have mild withdrawal, you are not administering buprenorphine. You are waiting until the patient has a score of 10 to 20, which is moderate withdrawal, or 20 to 30, which is severe withdrawal. And once the patient is in moderate or severe withdrawal, you'll be starting buprenorphine and being prepared to escalate the dose quickly if the withdrawal score remains severe after an hour. Still with us? This is kind of where the fun begins. Now we get into the actual administration of medication and the nuances of prescribing this. It's actually a pretty simple drug to titrate, but you just have to know what you're dealing with and what to do if a patient goes into withdrawal. So really, we're at the point of administering buprenorphine now. So let's get to know our options. You can choose between buprenorphine alone or buprenorphine naloxone combination product. And most emergency physicians are using the sublingual dissolving combination product, which has a well-known trade name out there. It's important to note that these dissolvable tablets may take up to 10 minutes to dissolve completely, so your patient is instructed not to talk, smoke, or swallow during this time. They basically tuck the tablets under their tongue or in their cheek and wait. Now, we're not allowed to use trade names, as we said, but this is by no means an exhausted list of all the buprenorphine formulations out there. There are other formulations on the market that are available to addiction medicine specialists, as we discussed. But X-waivered primary care and emergency physicians are really going to be talking mostly about these two products, buprenorphine alone in combination, buprenorphine with naloxone. So it's called OBOT, or office-based opioid agonist treatment. So on the left here, we have our screening labs. This is basically the list that everyone should be sending. So if you set up a program in your ED or your clinic, you'll have an order set. And then this ties directly into those special populations that may or may not be candidates for buprenorphine treatment. More interesting in the right-hand column here, in terms of doses, there are those out there that are actually advocating for much larger doses in the Yale protocol, and there are multiple clinical trials that may eventually prove that doses as high as 32 milligrams are both safe and practical in the ED. I just want to throw that out there because if you look on social media right now, if you go to your latest emergency medicine conference, there's a lot of talk about high-dose buprenorphine. We are simply not there yet. It is not prospectively validated. It is not evidence-based at this time. And so when you see the Yale protocol, it really is a start low and go slow approach, and that's what we're advocating at this time. When the literature gets there, if things change, we will give an updated webinar and we can talk about high-dose therapy, but that has not been proven yet. The Yale protocol recommends starting with a dose of 4 milligrams and increasing as needed in increments of 4 until withdrawal scores are near 0 or tolerable. I should say 4 or 2. Some people start with 4 and then go 2. In the ED setting, 4 is much more practical because the patient's not in the ED for that long. I know in my ED we have 13 beds. Sometimes those beds become very precious, and so you do want to kind of keep the flow going. The reasoning behind starting with 4 milligrams is that larger doses, if administered in an untitrated fashion, can theoretically trigger unanticipated withdrawal. So again, if you do accidentally precipitate withdrawal, the treatment is additional buprenorphine, 4 milligrams every hour, until the withdrawal symptoms subside. In terms of maximum dosing, the protocol recommends the following: a day 1 maximum of 8 milligrams. So if you were doing, for example, the 2 milligram tablets, that would be 4 of the 2 milligram tablets. And you can go above 8 if you're using that to rescue from withdrawal, but in general 8. A 2-day maximum of 16 milligrams, and then a 3-day maximum of 16 milligrams as well. And the dosing, we're going to have sort of a specific chart coming up, so stay tuned for that. If you do not have an X-waiver, the patient will ideally get their initial dose in the ED and then be seen in clinic on the next day. So for those of you that don't have an X-waiver yet but want to try this, you really have to work on that next day follow-up. And then in clinic, they can get their prescription. If the patient can't get to clinic the next day, for example, it's a weekend or an appointment's just not available, then the patient would have to come back to the ED on days 2, maybe even days 3, for a repeat administration until you can get an X-waivered provider to provide a prescription. Ideally, if you're X-waivered to prescribe, you can prescribe 22 milligram tablets to the patient on the initial visit, and then they would actually have those tablets so they can get to their follow-up visit. But again, you have to be X-waivered if you're going to prescribe. Do I sound like a broken record? I want to make sure we're all on the right side of the law here. So this slide here, I don't think we have to go too in-depth in terms of the take-home prescription, but it's basically all written out here. You could just take a screenshot of this slide and make this your order set for outpatient prescriptions. First, of course, make sure you're X-waivered. Second, write for 22 milligram tablets and let the patient self-titrate every 1 to 3 hours as needed for withdrawal symptoms. So again, if you're X-waivered, these are very short ED visits. You can basically observe the first administration, make sure your patient doesn't go into withdrawal, and then send them home to self-titrate. This is useful because the patient can titrate at home, and then when they go to their PCP for maintenance dosing, they can actually have an idea of what kind of dosing they'll need. As mentioned before, we have a preference for the buprenorphine naloxone combination medication from the ED just because it has a decreased risk of diversion, decreased risk of abuse. Now, depending on your patient's level of dependence, they may still experience mild to moderate withdrawal symptoms on buprenorphine. And I'm not talking about precipitating withdrawal. I'm just talking about on optimal therapy, they may still have some of these symptoms. So as we discussed earlier, if the patient is not fully in withdrawal, but just having some of the mild symptoms, you can give them some adjunct therapies to help with those symptoms. So ibuprofen is actually over the counter. So 400 milligrams by mouth for body and bone aches. That's any patient should be able to have access to that. The same with loperamide at the end there. If the patient develops diarrhea, they can get over-the-counter loperamide 4 milligrams and take it PO as needed. Depending on your system, you might want to put a process in place where the patient can get ondansetron or Zofran as needed for nausea. That's 4 milligrams under the tongue dissolving, oral dissolving tablet. Or for the patient with tremors or chills or tachycardia, clonidine 0.1 milligrams PO. I have heard of some centers that actually have little carry envelopes with these adjunct therapies in there, and the patient can take home their adjunct therapies as needed in case they do get withdrawal symptoms. You could also set up a system where you kind of know that your patients on buprenorphine therapy are out there, and if somebody calls into the ED asking for one of these medications to treat withdrawal symptoms, you could just reference their chart, make sure they were actually seen there, and then call it into their pharmacy. So that was the ED. Let's move on to the clinic. The buprenorphine induction plan for patients in acute care, an acute withdrawal in the clinic is really similar to that of the ED. Again, the Yale protocol is for ED induction, but you will find all sorts of protocols for very similar protocols for clinic induction. That's called OBOT, if you're looking for the term to Google. And the best protocol that we found is published by the British Columbia Center for Substance Abuse. And it's the first PDF that comes up if you Google prescribing buprenorphine naloxone. Prescribing buprenorphine naloxone. Put that in the search bar and you will find a beautiful 2-page flow sheet that can be printed out as an in-office reference. So I use this reference in the ED. We actually provided it as a PDF to everyone who registered for this webinar. But if you're registering late or looking at this at a later date, you can Google that search term and you'll find a very good graphic and flow sheet that explains this very well. Now, your initial visit is really about understanding why this patient's here and setting goals. And like we said before, the goal is to stabilize the patient's disease, meaning cravings. Try to help this patient establish quell their cravings so that they can establish order in their life and basically get their finances in order, go to their job, take care of their kids, do the things that people need to have stability and really long-term satisfaction in life. The first step to having long-term satisfaction in life is to get off illicit opioids and switch to prescribed buprenorphine. So to take this drug out of the streets and into the clinic setting, and eventually into the home prescription setting, which is really the difference between buprenorphine and methadone. And then you're going to make a plan so that the patient is in mild to moderate withdrawal at the initial visit. So you might have a patient who's still using heroin, and you say, okay, when do you want to get off heroin? Do you want to get off on Thursday, on Friday? Let's plan our buprenorphine visit. You're going to stop using heroin a few days before, and we'll make sure that you're in withdrawal in the time that you get to clinic. Now, the logistics are like the logistics of a lot of complicated therapies, although, you know, I'm not a primary care physician, but when I talk to my colleagues, they say that there's basically kind of an initial to-do here, and then once you get this rolling, these are pretty quick visits. So some of our primary care colleagues were initially concerned that these would be a very high maintenance patient population that's taking up their clinic time. The people I'm talking to are saying these are some of their most grateful patients, and the visits are actually very short once you get a plan in place. But initially setting up the plan, you obviously want to make sure that the patient's insurance is going to cover buprenorphine. So if they can't pay for the therapy, it's just not an option. And I'm happy to report that we're finding a lot of payers out there are starting to cover this at the request of patients. I mean, so many patients out there are suffering from opioid use disorder that payers are actually responding. You want to make sure that your patient is always using one consistent pharmacy. That's just good practice, so there's no diversion. So you can check the PDMP and make sure they're always going to the right place. You want to establish where and when urine drug screens will take place, so your patient knows that this is part of the therapy, is having urine drug screens. And then you'll review their screening labs that we talked about before. A note on urine drug testing. Urine drug testing is required. It really is required for patients on buprenorphine because we want to objectively document what kind of illicit use is going on, and what kind of prescribed medication use is going on. So we are not urine drug testing to be punitive. We're not saying if you test positive, you're out of the program. We want to facilitate open communication and let patients know, hey, we're going to be monitoring to see if you're relapsing here. Most providers are performing point-of-care urine drug testing at least monthly. And you have to remember that false positives do actually occur. And so if your patient says, hey, I'm not using, and your urine drug test says otherwise, just let them know that you have confirmatory tests and you're going to be proving that they're not using with a confirmatory test. But you don't have to call them out until you know for sure that you have good data. On the right-hand column here is a basic maintenance plan. The idea is that you're going to be checking in really frequently at first and then have more spaced out visits later. And so for the first 2 months, you're going to be doing a prescription every 1 week just to make sure that the dosing is right and the patient's doing okay. Obviously, the first couple of months are going to be rough. And then after that, you're going to be doing 2 prescriptions per month and then 1 prescription per month. And then just let the patient know that they should really expect months or years of therapy and that relapse rates are high, but you just have to roll with the program and stay on buprenorphine even if you relapse, because that's the way to survive on these dangerous drugs. Not buprenorphine, but opioids. Now, in terms of induction, the induction visit, getting it started in clinic, you can actually choose home versus office protocol. Most people I talk to are still doing office protocols. You're basically having the patient sit in the waiting room or in a quiet environment, and they are starting with a low 2 to 4 milligram dose, depending, once they have a documented withdrawal score of greater than 8 or really greater than 10 is ideal. And then you're just checking in on the patient every couple of hours until they get to a place where their cravings are controlled. There are protocols out there to do it at home. I don't know of a lot of people doing that in Wisconsin yet, but as we all get X-waivered and start having conversations and learn how to do this better, maybe that's something we can get into in our state. And then the PCPs I'm talking to are really trying to stack these visits early in the week on Monday or Tuesday so that you have Wednesday and Thursday to kind of troubleshoot if your patient does need dose adjustment. And then, of course, you do need a diversion control plan. The point of a diversion control plan is just to make sure that we're not perpetuating to the epidemic. So we want to make sure that these meds are not getting out into the community. They can theoretically be abused. Buprenorphine does not have the abuse potential of oxycodone or MS-Contin, but it can be abused. So we're going to check the PDMP. We're going to make sure that our patient is filling their prescription on time and that they're not getting their prescriptions from other pharmacies or other providers. We're going to ask the patient to sign a waiver so you can talk to their other providers and make sure that everything is above ground and there's no sneaky prescribing going on or opiate-seeking behavior going on. Let the patient know that there will be regular or random urine drug screens, regular or random pill counts. We want to trust but also verify that the patients are taking things as prescribed. And then really, you'll have a policy in place. So your ED or your clinic is going to have a buprenorphine policy, and be sure to share it with the patient. Say, hey, if you take this drug, you have to be able to lock this drug up. Your kids cannot be digging in the medicine cabinet and finding your buprenorphine. Buprenorphine can never be shared. It can never be sold. That's illegal. And it can only be taken as prescribed. So there are very strict standards here, and your patient has to respect those standards. And then really acknowledge and also sign a contract or a commitment to not divert, and that diversion is a crime. So, law enforcement will be informed if diversion is happening. And, we've had a lot of experience with contracts in the pain world, with pain contracts. I think patients are getting used to this commitment from the patient side and the provider side. And so hopefully this won't be too big a shock to this patient population. Okay, are you guys ready? Are you juiced? Are you excited? It's time to get your X-waiver. These are the steps. It's really not hard. First, you just have to be eligible. So you have to have a license and you have to have a DEA. And it's now available not only to physicians, but also advanced practice providers. So there is a large amount of providers in Wisconsin who can get an X-waiver starting today. You can start right now. You do have to take an 8-hour course. And if you look in the right-hand column there's many ways to take the course. So you can go all in person. You can do half in person, half online. You can do a live webinar for half of it, and then half of it sort of a pre-recorded module, or you can do all modules. I did the last option there. We have a link. It's called pcssnow.org, but it's an 8-hour MAT waiver training that is all online, basically modules. And it was good. It really was. I was on the couch. I did it over multiple days. I had my coffee, and I just did my X-waiver training. I felt that civic glow of helping my community afterwards. I learned a lot from it. I thought it was pretty engaging. They had a wide variety of different presenters, and not one of the presenters was dry. And so I would truly recommend it. I did it myself. I walked the walk. It was an easy 8 hours of CME that I was able to get reimbursed for through my hospital's CME reimbursement program, and I just really enjoyed it. Once you complete your 8 hours of training, you have to submit a notice of intent to this organization, the Substance Abuse and Mental Health Services Administration, or SAM-HSA. And then you will fax a certificate of completion of your training to that number on the screen. And when you finish your training course, they'll tell you all this again, so you don't have to remember this. They say it's a 45-day process, but mine was done in about 3 weeks. And so I'm really hopeful that our government is actually on top of this and providing us our X-waivers in a timely fashion. They sure did for me. And then look at all the opportunities, people. This is actually just the tip of the iceberg. So there's one in 11 days, there's one later this month, there's one in March, throughout the spring, really. Just quite a few opportunities to get X-waivered right now. And I know a lot of activist groups like ASAM are actually making sure that these are offered not just in Madison, Milwaukee areas, but throughout the state. And so if you don't see a waiver that works for you on this list, you can contact us, and we have even more options for you. And we'll be sure to plug you in with an opportunity that works for you. And with that, we are right at 8 or 9 minutes to go. I'm going to open the floor up for questions. Feel free to type it into the question bar there. And thank you for your attention.